Yeah, good day, everyone.
Good morning or good day.
Well, I'd like to welcome everyone to this session. And I'll thank Nat and everyone, Jessica. My name is Innocent Okwawu. I am the co-moderator for this session. I'd like my colleague to take it from here.
Okay. Good day, everyone, wherever you are. I'm coming to you from Houston, Texas this morning. We're so happy to welcome you to the fifth day of our Bloodless Medicine and Surgery Week. And our theme for this week has been Bloodless Medicine, the nuts and bolts. And Dr. Waters is going to take it beyond that. So we'll see how that goes. You know, we took a poll earlier in the week on Monday that showed that this webinar is being attended by participants from all different continents of the world, except Antarctica. Maybe someone's come on from Antarctica, we don't know. The program will feature a world-renowned academician and a clinician, as our keynote speaker. We've had wonderful keynote speakers all week. And then afterwards, we'll have a panel discussion involving clinicians from bloodless medicine and surgery programs, along with interviews with some patients. Just for housekeeping purposes, all questions should be put into the Q&A section. And if you're having trouble with Zoom, the program is being streamed live on the BMSS YouTube channel, and you can get there. And there's a link in the chat for that. And also, we want to minimize any talking and chats during the program. So just be aware to just keep your mute buttons on. And go ahead, Dr. Okowo, you're next.
Jessica, you can go on, please. It looks like he has an emergency.
Oh, okay. So we're going to hear today from Dr. Jonathan Waters. I don't have all his information right here, but he's going to talk to us on the topic, as I mentioned, blood salvage and bloodless surgery, more nuts and bolts. So we really enjoy hearing from him and really getting the information on autotransfusion and what's the latest and greatest. Thank you, Dr. Waters.
Thank you, Jessica. Can you hear me?
Yep, very clear.
Okay,
Very well.
Great. And so I'm going to share my screen. At least I think I am. All right. I'm going to speak this morning. By the way, it's 8 a.m. here in Pittsburgh, where I'm speaking to you from. I see it might be 1 p.m. in the afternoon in Nigeria. And I would guess that Jessica is early in the morning at 7
a.m.
7 a.m. Yeah. Anyway, I want to thank everybody for participating in this program. It's something that's been near and dear to my heart for about 30 years now, where I first got involved in bloodless medicine in Cleveland when I was at the Cleveland Clinic, where I met an individual by the name of Sharon Vernon, who kind of introduced me to these concepts. And what I quickly came to recognize is that patients of all colors and creeds did better in their surgical management when they were treated in a bloodless fashion. So, and we really have expanded from the bloodless terminology to blood management because it's all encompassing. The bloodless component of it is just kind of what I would describe as the goal. But sometimes in patients that are not bloodless, the whole spectrum of care is identical. Now, I think the heart of any bloodless program or any blood management program really should be autotransfusion, or what has been labeled blood salvage. And there's some synonyms for this particular technology: blood salvage, intraoperative blood collection and reinfusion, autotransfusion. It simply means that you're collecting the patient's own blood, doing something with it and reinfusing it. And so that's what I'm going to talk to you about today. So these are some of my disclosures. I do some consulting work for LivaNova, which is a company that manufactures auto transfusion devices. Likewise with Humanetics, they make an auto transfusion device. And then I also am on the board of trustees for Vitalant, which is the largest independent blood bank in the United States. So to start off with, this is where I'm speaking to you from. This is Pittsburgh. In the foreground of this particular slide is the University of Pittsburgh, with the tall building kind of towards the right side of the slide being the Cathedral Learning, which is the center of the university. And in the background of the slide is the downtown Pittsburgh, and you see the tallest building there is UPMC headquarters. That's the University of Pittsburgh Medical Center. We're the largest employer in the state of Pennsylvania with about 180,000 employees, providing health care, and 43 hospitals in the United States, and then 18 hospitals in overseas locations. So this is to orient you to the geography. This is where Pittsburgh is located. And this is the city itself. And I'll outline the importance of this in a moment. But Pittsburgh is formed in the middle of two rivers, the Allegheny River and the Monongahela River, which forms the Ohio River, which in turn flows into the Mississippi River. And the city of Pittsburgh sits in the confluence of these two rivers. And so I wanted to talk a little bit about the history of allogenic transfusion, and then migrate into autologous transfusion. Allogenic means that it's blood being transfused from somebody else. Can either be a person or an animal. And then autologous transfusion is transfusion of blood from the individual. So this all started with William Harvey back in 1628, where he discovered circulation. And we might think of this being very intuitive, but at the time, people thought that the blood was circulated in two different circulations, one being the right side of the heart and the other circulation being the left side of the heart. There was no understanding that there was a connection between the two. And the right side of the heart carried blood that was blue, and the left side of the heart carried blood that was red. Neither should meet, at least that was the understanding in 1628. And William Harvey was brilliant by doing some experiments where he demonstrated that the blood was all flowing in one direction through the valves of the venous circulation. So around the same time, this concept of blood transfusion was launched. And this is a woodcut showing the first transfusion that took place in an individual who had what sounds like schizophrenia, or could be neurosyphilis, where he was transfused with blood from a goat, or a sheep rather, thinking that the sheep blood would make him more docile. And so there is some mythology around this particular transfusion, in that this individual ultimately succumbed to his anemia, or his wife's cyanide. But at any rate, there is some information in the literature that says that the Pope in Rome banned transfusion practice at this point. There is some controversy as to whether that truly happened, though there was also the French Society of Medicine decided that this wasn't a very good treatment either. So this really kind of stopped transfusion, at least for the next 150 years, until James Blundell in 1818 published a report, as he observed a woman died during childbirth, and this unfortunately happens about 500,000 times around the world, where somebody dies during childbirth. And this was James Blundell's solution, was to basically transfuse human blood. And in this era, it was typically blood from the father, as is demonstrated here, where the blood was transfused from the dad into the hemorrhaging mother, and hopefully was life-saving. And then in 1819, Blundell published a case series of 10 reports, where this is the way that it was done through this Blundell blood gravitator. But this particular technology didn't really catch on, and for a couple reasons. One is that the results were somewhat haphazard, because there was no understanding of blood typing. So, if you're transfusing somebody with a blood A type to somebody that has a blood B type, it's going to be a fatal transfusion. So there's no benefit. There was also no ability to anticoagulate the blood. And so the blood had to be transfused direct from the donor to the recipient. And so these obstacles really prevented widespread use of transfusion medicine. It wasn't until this gentleman in 1918, during the First World War, really advocated for the use of citrate to basically anticoagulate the blood and then transfuse it. And this is kind of the initiation of the modern day blood bank, was through this individual, Albert Houston. So getting back to the map of Pittsburgh, this star here represents where bloodless medicine started. This was where the Jehovah's Witness church was founded, and this is a plaque memorializing the location of the original Bible Tract Society on the north side of Pittsburgh. So in this region, we take care of a very large number of these patients that require bloodless interventions, and it sums about 1,600 patients per year that come into our hospitals. So we have to be respectful of their wishes, like any other patient. And so we've developed, I think, pretty much the premier bloodless program in the United States, and it's because we have such a large patient population of these patients. And so I'm going to get a little controversial here. These are some of the scriptures that identify why the Jehovah's Witnesses prefer a bloodless healthcare. And it basically is that blood should not be consumed. And it's interesting that if you look at what will be accepted by bloodless medicine patients, and this is a position paper that comes from the Watchtower, which identifies what is acceptable and what is refused by this patient population. It's interesting that the major components of blood are refused, but there's some fractions that are left to the personal decision-making of the individual. And this is where it gets kind of cloudy. And I think this is what is confusing for many healthcare providers, is the refused products and then the potentially acceptable products. So, as a healthcare provider who is not a Jehovah's Witness, I find this particular page on the website of the Jehovah's Witnesses to be particularly useful. There's some information here for clinicians in what is acceptable and what is not. And I would encourage any physician that's caring for these patients to seek out this information. And this highlights from the Watchtower, the need for personal decision making being incorporated into the care of these patients. And I think this is really important, and we've kind of leveraged this concept for our use as it relates to autotransfusion. Autotransfusion is, again, the collection of spilt blood and the processing of that blood and then the reinfusion. And some Jehovah's Witnesses will accept this processing and some will not. And usually what we do when we get patients that are against the autotransfusion, we'll generally bring in church elders to speak with the patients and determine whether they truly understand that it's their own blood that's being used. And in the vast majority of circumstances, this will get acceptance. Now, as I was putting this lecture together, this particular statement jumped out on a Google search that I did, where these are some statements made by the Roman Catholic Church that the act of donation of blood is an expression of human solidarity and of Christian charity. And I thought that this was in somewhat contrast to the teachings of the Jehovah's Witness Church, and which leads me to some comments about what's going on here in the United States, where there are certain states, Texas, Jessica, you may be aware of this. Texas is in the process of mandating that patients have access to their own blood for transfusion. The state of Montana has also passed forward legislation that defines that a patient should have access to blood from patients that have not been vaccinated. So we've thrown in this huge, not only religious schizophrenia, but we've also thrown in politics into the transfusion of blood. And I think that the way we get around all of these individual perspectives is through the use of autotransfusion, where the patient gets their own blood. They're not exposed to a patient that's been vaccinated or somebody that is walking around with blood that they don't want. So that leads me to the history of autotransfusion, or the transfusion of a patient's own blood, which started with this publication in the Lancet by William Highmore, who is a physician, once again in England, who, in the observation of a mother bleeding to death in bed following delivery, and he thought, wouldn't it be great if we could collect that blood, defibrinate it, warm it, and then inject it right back into her. And if you look at the bottom of this particular statement, this is what it says. And this is kind of the first report that I'm aware of autotransfusion, though there's some reports earlier of autotransfusion, but this is the first really published account of doing so that I'm aware of. So this was the primary way of transfusing patients for about 50 years until Albert Houston discovered citrate anticoagulates blood. But there's a number of case reports in the literature of autotransfusion being performed. And this is one of the reports from this journal, California and Western Medicine, where they reviewed 272 cases. And these cases were mostly ectopic pregnancies where the blood was collected. and reinfused. And this particular idea evolved into the Bentley autotransfusion system, which is shown here, where the sphere on the top of the device was used to collect blood. It was suctioned out of a bleeding patient, this is shown on the right side, and stored in this reservoir, filtered, and then pumped right back into the patient. Now, this device didn't have a long lifespan because the roller pump on this device wouldn't stop when the reservoir would empty. And so there was a number of case reports of air emboli occurring from the use of the Bentley autotransfusion system. So it was taken off the market pretty rapidly, but it was an extension of this whole concept of autotransfusion. So now we've evolved into having these more sophisticated devices. This is a picture of a device that I used at the Cleveland Clinic. It was a Medtronic Sequestra. And just showing you the pieces and parts of the device with a primary reinfusion bag where all the action is occurring. Now, the reason I think autotransfusion should be at the center of any bloodless program is illustrated by some mathematical modeling that I published probably around the year 2000. And this is a mathematical model of a patient bleeding. And this dotted line is representative of the bleeding. And the x-axis on the bottom represents the amount of blood loss. And the y-axis on the left of the slide represents the patient's hematocrit. So if we started with an idealized patient with a hematocrit of 45% and a body weight of 70 kilos, this patient would be able to tolerate about 3 liters of blood loss with no intervention other than just volume support through crystalloids or colloids. Now, if you add autotransfusion onto it, the curve looks a little differently, where it looks like this sawtooth, where if you take the same starting point of a hematocrit of 45% and you bleed, at some point you've collected enough blood that you can transfuse that blood back to the patient. So that's what leads to that sawtooth, where you retransfuse the blood that's been lost. So there's a bump up in the hematocrit. And so as the patient bleeds during the course of their care, you have a technology that is able to take somebody that would only tolerate about 3 liters, you take them out to being able to tolerate about 8 liters of blood loss through this technology. And there really is nothing else in our medical armamentarium that allows for patients to tolerate this kind of expansion of their blood loss. And so just to compare, no techniques being applied on the top and the autotransfusion on the bottom. And so you can see we can take somebody that's starting at a normal point and just expand double and sometimes triple. And my own personal record for this particular technology is transfusing 271 units of blood from an autotransfusion device in somebody that had a ruptured thoracoabdominal aneurysm. So it's really pretty astounding what it's capable of doing. And so this is kind of the heart of our blood management program. And this is what I describe as our 6 steps of our blood management program, with autotransfusion being item number 3 here, highlighted in red, being the key. And I think this is really, I think, the heart. You can talk about anemia management all day, but it's not going to allow you to tolerate 10-liter blood loss. So we have a number of devices that are available to do this. And there is also some devices that have been introduced. The device on the right is the HemoClear, which is basically a filter. The device on the left is the basically a giant syringe that sucks blood out of a patient. You flick a stopcock and then you pump the blood back into the patient. The device manufactured by Sisu allows for use in the third world where you can't use a device that requires electricity and all of the drugs that go along with providing that product. So intraoperative autotransfusion can be used in a lot of different environments, as illustrated here. And I guess my time is growing short. But this was a paper that was published, or a report of the care of a patient, a Jehovah's Witness, who refused autotransfusion. And these investigators advocated doing it with a continuous circuit. And I've talked with the Watchtower on a number of occasions, and they don't really understand how this idea came across, where the continuous circuit was necessary. And I think that it was a marketing scheme. These devices process in batches, whereas this device, the one on the left, the continuous autotransfusion system continuously processes, so you can continuously provide blood that's washed with this device. And I think it was a marketing ploy from the company that manufactures this device to get Jehovah's Witnesses to advocate for this continuous circuit. And I don't really think this is necessary, and the Watchtower seems to agree with me. But if you want to do this, this is how you would strategize your reinfusion, is through here. And I'm just going to flip through the instructions on how you would go about doing that. I guess Nathaniel is going to post my slides so you can read through that recipe of how you might do it if you want to do a continuous circuit. One of the things that's necessary to make autotransfusion efficacious is rinsing of your sponges, as is shown here. And you can remove about 95% of your cells through the rinsing of sponges. Once again, this is the patient's own blood that you can return to them. So just to finish off, I want to just highlight some of the differences between autotransfusion red cells or autologous cells and blood that comes from the blood bank. This is some work that was done with radio labeling of red cells, those that were washed and those that were unwashed, and the lifespan of those cells was basically identical for this particular study, or in this particular study. And the shapes of the red cells maintains its normal integrity, as is demonstrated on the left, where they take on an echinocyte shape when they're stored for a couple of weeks, as is shown on the right. And then there's been some work done looking at contamination of stored blood. This is some of it, fibrin degradation products, which is breakdown products from clot, where if you look at washed blood, it provides something that's equivalent to what's circulating in the patient. Plasminogen activator and activator inhibitor are also washed out. Complement, likewise. Elastase, which is an enzyme that comes from white cells, is also washed out to a level of what's circulating in the patient, and serotonin also. So I equate blood from autotransfusion to this steak. A The steak on the right has been refrigerated 21 days, which is the same length of time that blood is stored. The steak on the left is straight from the butcher. And this is the difference between a blood bank unit that's been stored and cell salvage blood. The blood bank unit that's been stored has that kind of brownish color, whereas the autotransfusion blood looks fresh and healthy and whole. And if I was eating that steak, I'd rather have the one on the left that looked fresh. And likewise, if I'm getting transfused, I'd prefer to have blood that looks red and healthy and pink. So again, this is our strategy, and I will defer to the Australians who came up with pillars instead of steps for what they advocate for their autotransfusion program. And I think I will end there, having expended my 30 minutes, and just leave it for any questions. Or if Nathaniel wants the questions to be left for the panel, that would be fine too.
Thank you so much, Dr. Waters. You guys have today had the privilege of listening to Dr. Jonathan Waters, who is currently a professor in the Department of Anesthesiology and Bioengineering in the University of Pittsburgh. He's the chief of the Division of Anesthesiology at McGee Women's Hospital of the University of Pittsburgh Medical Center. And he's also a member of the McGowan Institute for Regenerative Medicine. His areas of expertise primarily focus on transfusion management, blood salvage, and obstetrics. He has been federally funded to support investigation in these areas with over 150 peer-reviewed publications, 5 books on the topic of blood management, and a book on neurologic disease in pregnancy. In addition to conducting research, he has served on the editorial board of the journal Transfusion and is currently serving as an associate editor. He is past president of the Society for the Advancement of Blood Management, and he served on the board directors of AABB between 2011 and 2015. He chaired the Blood Management Technical Advisory Panel for the Joint Commission from 2007 to 2016. So we've really heard someone of great expertise. And I call the autotransfusion systems that he spoke about the Ferraris of our bloodless medicine devices, because they're turbocharged like the 208 GTO that my husband so admires. So there are just wonderful tools that we have and devices that we have to help patients recover from blood loss. One of the questions, I hope some people are putting some questions in. One of the questions that I had, you featured an article about that really autotransfusion began with a individual noticing the postpartum hemorrhage of a patient and, thinking about reinfusing that blood. But why are there so many contraindications for obstetric reinfusion of blood?
Well, that's a simple question. It's because of the FDA. When our machines first came into use, the FDA wanted studies done in pregnancy, and the manufacturer, whose Haemonetics, or what became Haemonetics, didn't want to do those studies because the sample size was unwieldy. It would have required a study of about 1.5 million patients. I've never seen a study of 1.5 million patients. So the solution was that they just labeled the devices contraindicated for obstetrical hemorrhage. And so that was where the myth came from, that you couldn't use it. The current machines, I think we're into the 5th or 6th generation of autotransfusion machines, do not have that labeling. And I'd like to think that it's because of some of my publications where we've demonstrated safety. And there's currently around 2,000 case reports in the literature, of obstetrical use of autotransfusion with no adverse outcome. I think if you go back to the inception of autotransfusion being used in obstetrics, then it should give you some comfort in using the modern devices in this particular domain. I will stop there. It looks like Yvette has a question.
Go ahead, Yvette.
Thank you, Jessica. Dr. Waters, it was mentioned earlier on during our presentations that there is a shortage of cell salvage supplies, which might discourage someone from using cell salvage. Could you comment on that? I got a little bit of background on that, but I don't want the idea of there being a shortage of supplies to discourage someone.
Well, I think it's a shortage of reservoirs from one manufacturer. We have gotten reservoirs from other manufacturers, and we've kind of jerry-rigged our machines so that they can be used with that new reservoir. There's also something called the HemaSaver, which is a device that's kind of a standalone collection reservoir that we've purchased, and we're able to connect those devices to the processing component of our cell salvage machine. So I do recognize that as being a problem, but there are workarounds that can be put into place. And I'd be curious to hear about what your background information is.
What I was told, same thing that you're saying, that it was mainly the canister, and a lot of these were produced out of Italy. And of course, Italy has been hit with a lot of natural disasters. Another company, they were using Mexico, and so there was a supply issue. But we too used the HemaSaver and canister and didn't have any problems. So I appreciate your comments, because I was afraid that that might discourage some from using cell salvage. So thank you very much.
Sure, thank you.
So we do have a couple questions in the Q&A section. If 2 units of blood is taken from the person through cell salvage, what % is returned?
Well, it depends on the patient, and depends on, it's a whole nother lecture. But it's variable. I think on average, you're able to return about 60% of the red cells to the patient. If you're sucking that blood out of a deep reservoir, for instance, a ruptured aortic aneurysm, your salvage rates or your efficiency is much higher. It's more like 80%. And I think there's some other things that you can do to maximize the recovery. But it's a high amount. And I think, if you have a patient that's accepting of hemodilution, which is where you pull blood out before the blood loss happens. My own personal example is my father underwent 8-level spine fusion and instrumentation. He lost 13 liters of blood, and we hemodiluted him and used cell salvage, and he tolerated the 13 liters of blood loss. And his hemoglobin was only about, say, 5 grams below where he started after a 13-liter blood loss. And that was 2 entire blood volumes that he tolerated losing. So you can do a lot with these systems, that is, really life-saving and unusual. You just have to have a little bit of knowledge in how to do it.
Thank you for that answer. In regards to using cell salvage in obstetrics, are there concerns with amniotic fluid contamination?
Amniotic fluid is feared, but if you look at every woman delivering a baby, there's going to be incorporation of amniotic fluid into their circulation. So we don't really know what leads to the amniotic fluid embolic phenomena versus what is routinely happening at childbirth. And I think the literature has migrated towards thinking that it's more of an anaphylactic reaction to the amniotic fluid than it actually being components of the amniotic fluid. So, amniotic fluid embolism, if it is an anaphylactic reaction, the treatment would be high dose epinephrine. And I've experienced one of those in my career, and that's exactly what I did, is gave large quantities of epinephrine, and she survived. So I don't know. I don't think amniotic fluid is something to be feared.
A few times I've talked to a number of our PBMTs who run our cell salvage systems, and they talk about suctioning is very important, where you're suctioning from and what you're looking at. Can you speak to that a little bit? Do you train your technicians to look out for certain things when they're suctioning the blood into the device?
Well, you don't want to suction. First of all, you don't want to suction frank stool because of the bacterial content. But you can do surgeries on the bowel, where there might be traces of bacteria. Once again, though, that's a completely separate talk as to how you do that kind of processing. You don't want to incorporate drugs. For instance, in OB, misoprostol is a profound vasodilator. So if you incorporate misoprostol into the blood, you may have a drop in your blood pressure upon readministration. Other drugs like oxymetazoline, which is Afrin nasal spray, if you incorporate that, you get the opposite, which is hypertension. You want to avoid some of the microfibrillar collagen hemostatic agents, which can cause DIC in a patient. But these are all things that are in the surgical field. You just wash them out and then go back to using your cell salvage suctioning. I would suggest reading one of my books.
Very good. Very good. Do any of our panelists have any questions or comments?
Jessica?
Yes.
There's a recent article on autotransfusion of vaginally shed blood as a novel therapy in obstetric hemorrhages. Is this technique being done in your institution? Do you have any experience on it?
Yeah, actually, that's my publication. So yes, we do have experience. I think the case that you may be referring to is a case report of 65 cases of vaginally suction blood. We have also published on how you orchestrate the suctioning of vaginally salvaged blood, the process that are necessary to try to minimize the amount of amniotic fluid. That was a separate publication. And then we are currently working on a paper looking at the bacterial contamination, which I think is overrated. Anybody that has bacteria in their wound, it will be suctioned into the salvage device and reinfused. But if the patient already is exposed to it, why is it dangerous? I don't fully understand, the logic. But we can remove that bacteria with filtration. And if you give a little antibiotic on top of it, there's no evidence that there is going to be an increase in infectious complications in a patient that has blood, suctioned from a potentially contaminated, bacterially contaminated site. And the other thing that's coming out with the discovery around the microbiome is that there are 28 bacteria that normally live in our blood, which is kind of a radical idea. So it's like any disease process. It seems to be that disease occurs when there's an imbalance, of the bacteria. It's not necessarily its sheer presence. So I think we're in for a revolution, as it relates to bacteria in the future years. I hope I answered your question. But
Yes,
yeah,
thank
we
you.
do it.
Thank you, Dr. Gapay. One more question in the Q&A. Would we consider as a blood transfusion the blood collected from a patient during the ANH process once it stays out of the body for some time, minutes or hours?
Yeah, I mean, you can do it where you maintain contact with the circulation. You just pull the blood out of the patient and then keep the blood connected to the patient. And again, it boils down to, what is acceptable to that individual. If it's their own blood, usually, at least in my experience, and maybe you guys can comment, in my experience, if it's their own blood, it's far more acceptable than somebody else's blood. And Yvette and I have had conversations about this, and that she wants me to open up my training program to a wider audience, and I just don't have the bandwidth to do so. But I would be happy to travel to South Carolina, especially in February, and show you how to do it. But anyway, I think, with a certain amount of counseling, hemodilution or ANH can be done with the witness population.
Thank you so much. So Dr. Akawo, do you have anything you want to add to the discussion?
Yeah, thank you. Well, I'd like to start with thanking Jonathan Hughes with taking you up your sleep. Just to this last question. First, I'd like to use the phrase reinfusion rather than transfusion.
Excellent idea. Yeah.
Yes.
I love it.
Yes. So it's and then usually what I do for ANH, I use a central line. So maybe a femoral or a subclavian. It has three channels. So I use the central line to do the collection and leave it in continuity with the patient, while we can use an anticubital line for our usual medications and anesthesia or whatever medications we intraoperatively. So we usually would leave the blood in continuity with the circulation while the surgery goes on. So, and that's been acceptable for a lot of our patients. I haven't had experience with cell salvage either, because in my center we don't do we've not encountered procedures that would require whole blood volume losses. We don't do cardiac surgeries, but orthopedics, yes. Some thoracotomies, we collect blood from the pleural cavity post thoracotomies and reinfuse. So and that has helped. What we haven't done a lot is from the joint spaces, maybe after hip arthroplasty or knee arthroplasties, we haven't had the courage to collect blood from those spaces post-operatively. But once again, I hope someday I come to Penn State and spend some time with you.
Yeah, excellent. You're always welcome.
Okay.
Our next part of our day is our multidisciplinary panel discussion on the theme Bloodless Medicine and Surgery Programs all together now. I know Yvette spoke yesterday about the team and getting the team together. And to lead our discussion will be Dr. Nathaniel Usaro. He's the chairman of the Bloodless Medicine and Surgery Group in the University of Calabar Teaching Hospital. He's the president of the Bloodless Medicine and Surgery Society. Dr. Usaro will go on to introduce the members of our panel today.
Thank you very much, Jessica. As has been pointed out, the theme for our panel discussion is Bloodless Medicine and Surgery Programs, all together now. Why that sort of theme? Because our focus is on how bloodless medicine and surgery programs function in a multidisciplinary manner to produce excellent outcomes for patients. So it's not about the surgeon or the anesthesiologist or the nurse. It's about everybody that is involved in that care. And I would appreciate if our host would spotlight the members of the panel. You can see the Dr. Stephen Frank, who is a professor of anesthesiology and the medical director of the Center for Bloodless Medicine and Surgery, Johns Hopkins Health System, Baltimore, Maryland. Welcome, Steve. And beside him is Isha Shed. She's a nurse coordinator in the same program, the Center for Bloodless Medicine and Surgery, Johns Hopkins.
Good morning. Thank you for having us.
Thank you for joining us, Steve. Then we have Mindy Jackson. You can keep adding to the list, please. Mindy Jackson is a PBM and Bloodless Medicine Coordinator with more than 25 years of service as in critical care, cardiac, and case management nursing. But in the recent period of time, in the past 4 years, she's been devoted to bloodless care. And I'll come back to this, but it's interesting, the note she sent to me, she says she believes that she should promote this as a gold standard of care for all patients. That's interesting. She's at Putnam Hospital, part of Novant Health in the US. Welcome, Mindy.
Thank you very much. I'm honored to be here. Thank you.
And we have also Deborah Abru. She's the Bloodless Medicine and Surgery Coordinator in Lawrence Hospital Center, Bronxville, New York, in USA. Is Deborah here?
Deborah doesn't seem to be here at the moment.
Okay, not yet here. All right. Tanisha is here. Tanisha Davis is Administrative Director, Patient Blood Management in RWJ Barnabas Health System. I hope I pronounced that right. Livingston, New Jersey, USA. Welcome, Tanisha.
Thank you. Thank you for having me.
And we have another doctor, Dr. Monde Godwin, who is a consultant obstetrician and gynecologist with the Nigerian Air Force Hospital in Ikeja, Lagos, Nigeria. Welcome, Monday.
It's a pleasure to be here. Thank you very much.
We also have some patients with us. And first one I'll mention is Lisa Evenson. I'll just say that she's a patient. She'll talk about herself later. One of the patients that we'll talk to. Welcome, Lisa.
Thank you. Happy to be here.
Another patient is Dorcas Joseph. Welcome, Dorcas.
Thank you. Glad to be here.
And last and not least, it's Irizim Gania. Irizim.
Yes.
Hope it's not sounding like a
Yeah.
secondary school roll call. Welcome.
Thank you.
So, I'm very privileged to have all these wonderful people here with me. And let me start with Dr. Steve Frank. So, Dr. Frank, you are not only a professor of anesthesiology, but you are also the medical director of the Center for Bloodless Medicine and Surgery in one of the, I must say, top hospitals in the world. Some would say the top hospital, Johns Hopkins. So I think you're in a very good position to let us really know what really is the Bloodless Medicine and Surgery program. What does it aim to achieve?
Sure. Good morning again, Nate. We're privileged to be here, and beside me is Isha Sherd, our clinical coordinator. So what is it? Well, we think it's the best way to practice medicine because we're giving patients optimal care because the best thing to do, we've learned over the last 10 years, is to keep the blood in the patient because that's where it belongs. And there's no better blood than your own blood. And certainly the blood in the blood bank is not fresh. It triggers an immunologic response, so patients can form alloantibodies. There's allergic reactions. There's trally and taco. I've seen 2 deaths from taco in the last 5 years, so it's real. And I'll tell you, when I bring a Jehovah's Witness patient in for a specific surgery, the surgeons will lose half as much blood. And I know that sounds odd, but when they try harder, they lose less. And if they can keep the blood in the patient, that's what our aim is, and the patients do better.
Very interesting. Just 2 days ago, we had Dr. Pinet Carlo, the head of anesthesiology in my center. And you know what? She kept repeating what you're saying. She said, I learned this from Dr. Stephen Frank. We should keep the blood in the patient. So I must have missed it when I was with you in Johns Hopkins, but she remembered. And now I'm hearing it again from you. Now, tell us about the BMSB in Johns Hopkins. When and how did it start? And what is the setup like, the organization?
So it was 10 years ago. And the chairman of my department said, Steve, we need someone to handle these Jehovah's Witness patients because no one wants to take care of them. And I said, what do you mean? Well, they had a list of anesthesia providers that would or would not take care of Jehovah's Witnesses, okay? And you could sign up to be on the yes or the no side of that list. And I thought, this is crazy because if we do things correctly, everybody should be on the yes side of the list. And what it was is there was no team and no program, okay? So it was just throwing the patient to the wind, okay? When we started the program 10 years ago, and we did aggressive pre-op anemia treatment, We made sure that the cell saver was available. We used tranexamic acid. We keep the patients warm during surgery. We use controlled hypotension. We use ANH when necessary. We use smaller phlebotomy tubes. And when they saw that we had a team and a program, then all of a sudden everybody was willing to take care of the patients in the anesthesia department. And we only have 2 people out of 100 now. Okay, 2 out of 100, and I know who they are. And they prefer not to have Jehovah's Witness patients. So that's how it happened.
Wow, 2 out of 100, not bad. Okay, so let's hear from someone else who is with you there, and that is Isha Shed. How long have you been working in the BMSP in Johns Hopkins?
Well, I've had a privilege to join the team back in 2014. I was a new grad on the critical care unit here at Johns Hopkins. And it just so happened that I came across the administrative coordinator, who's still with us today, Andrew Pippa, and they were looking for a volunteer to be able to go see patients while different team members were away on vacation. So I thought this was a great opportunity that I would be able to dip my toe into bloodless medicine, being a new grad and really understanding that aspect in patient care. And then I was asked to join the team in 2014. I told Dr. Frank, I'm young. I don't have much experience, but I'm here and willing to learn. And I've learned so much under his guidance, as well as Dr. Reese, our hematologist, and the rest of the team as well.
That's wonderful. You've hit on a point there. We all start as volunteers. Even Dr. Frank started as a volunteer, saying yes when others said no. That's great. Tell us about your role as a nurse coordinator at the BMSP in Johns Hopkins.
Absolutely. So we were privileged to be able to set up our team where we have many different members who are able to take care of each unique aspect in our bloodless care. So for myself, I focus on the inpatients primarily, whether that's patients who come in from after surgery, post-operatively, patients who are transferred to our hospital for bloodless care, as well as patients who come into the hospital for medical concern. So I'm able to go visit them daily. I do education while I'm rounding on all of the patients with many clinicians, including the nurses, nurse educators, doctors, intern, etc. And then also too, I'm able to help out our bloodless hematologists and our nurse practitioner in different consultations. When the medical teams, the primary care teams put in for a consult, I'm able to assist them as well. And then just to keep our team organized and make sure that everyone is abreast on all of the patients that are in the hospital and who are under our bloodless care, I send out daily updates to our whole team so that each day we all know what is happening with our patients. And that's very critical because then we're able to keep a running list. We're able to look closely and monitor all the lab work, blood work, doctor's notes. And so we really understand what's going on. And if we need to jump in or intervene or prevent anything from happening, our whole team is aware and on board.
That is a full schedule. Now you can take this one as my own quote, okay? And say that Nat was the one that said this. So we can say that a nurse coordinator is the lifeblood of a bloodless program. No pun intended.
This is definitely a team sport.
Absolutely.
And we have 6 members on our team. And whenever we get a patient that's admitted or a patient that's a challenge, we have a chain of emails and texts with all 6 of us on the team. And so we all know what's happening with each patient. And we communicate day and night, weekends, holidays. I mean, that's the thing. We're always available 24/7. And that's in some ways that's a drawback, but it's also the benefit to the patients that we're always available.
Thank you very much for that. Let me ask again, Isha, what has been the reaction of your patients? I mean, to the care that they receive in the BMSP. And of course, you're free to share any anecdotes if you have.
Oh, yes, we actually have one of our patients that's logged on. So I'm very excited for you guys to be able to hear her testimony on how things went as a bloodless patient. But truly, all of our patients are grateful and appreciative for all of the care that we have given them, whether it's from the pediatric perspective and supporting the parents. Our administrative coordinator and our program coordinator are wonderful in being able to support them, helping them understand different rules and regulations and law regarding minors. And then also too, our patients who are here just because they have a medical issue. They may not directly need us in our care, but our daily visits with them are really encouraging them, knowing that we are here. They have a team, like Dr. Frank said, available to them 24/7, that we are making sure that everything is okay, and that if they have any questions or concerns, they're more than welcome to reach out to us. As well as we go over their bloodless worksheet, making sure they have their advanced directive. If they have any questions about minor fractions or different equipments and procedures with the use of their own blood, we're always there to answer morning, noon, and night to make sure that the patient's autonomy is respected and that the clinicians understand that they are speaking the same language. And truly, there is no greater joy than looking in a patient's eyes, seeing them say thank you, and really knowing from the bottom of their heart that they truly appreciate everything that you have done for them.
I agree with you completely, because I have seen some of your patients when I visited, and I agree that they're all happy about the care that you're giving. Let me go back to Dr. Frank. So you started with just yourself initially saying yes, and then others, and then now out of 100, just 2 are not saying yes. And you started with Jehovah's Witnesses. Now, how successful has the program been? And is it having an effect on the rest of the hospital?
Sure. So I like to say that some of the best practices that we've learned from our Jehovah's Witness patients have now carried over to the 99% of our patients who are not Jehovah's Witness. A simple thing like smaller phlebotomy tubes. We've gone throughout the whole hospital to the pediatric size tubes. And then other things like tranexamic acid, we've learned to dose it properly for different types of surgeries only in the last 10 years. Use of the cell saver. You know, surgeons, sometimes they don't use it well. They'll have like 3 suctions and only 1 will go to the cell saver. The other 2 go to the waste suction. So you learn lessons from Jehovah's Witness patients that benefit all of our patients. And I think some of our practice has spilled over into the general population because I'll tell you what we've noticed is the overall blood use at Johns Hopkins has dropped by 20% in the last 10 years. And we owe some of that to what we've learned from our bloodless patients.
That's fantastic. And right now you are demonstrating clearly what you were talking about, the multidisciplinary nature of the practice, because you're sharing a screen with Isha. That's great. Do you think the multidisciplinary nature and the synergy among the workers, say there are 6 of them in your BMSP, do you think it has contributed to its success?
Sure. I mean, we've got a full professor of hematology on our team, Linda Resar, and she does consults on patients for anemia management. And we don't just throw iron at all of our patients. I mean, we tailor the approach to the cause of their anemia. And doing an anemia workup can be complicated. It's not just simply giving iron to every patient. And then we have Isha has been with us for 9 years. She knows the ins and outs. She talks with the family members. We have their cell phone numbers. It's a very personalized type of medical care. I mean, how many patients have cell phone numbers of their doctors and nurses? That just doesn't happen. But in our patients, it really does. So we're a tight group. And we have not only Isha, but we have Liz Hendricks, who's a nurse practitioner. So she can do consults and write orders. And then we have Andy Pippa and Patrick, our new coordinator, who has 25 years of bloodless experience from programs in Philadelphia, where we recruited him from. So we definitely have a strong team, and we have brought in, let me tell you one more thing, the financial impact, okay? I told you about the 20% drop in blood use across Hopkins. So we are saving $4 million every year because of that in blood acquisition cost. But with our Jehovah's Witness patients that we bring in, we're bringing in $12 million of revenue per year and $5 million of margin, okay? That means after the cost of care and our program is subtracted, we're bringing in $5 million. So with the 4 million of blood savings and the 5 million of patient care revenue, that's a $9 million a year benefit to the hospital. And so the hospital leaderships, they love what we're doing.
Go to another nurse. So, Mindy, we're very happy to have you here with us. You have just won a nursing award as part of the Nurses Week that was celebrated last week. Tell us about the award. It's related to your work in bloodless medicine and surgery.
Yes, it was a huge surprise. The New York Hudson Valley Magazine pays tribute to nurses from healthcare organizations throughout the region. And I was nominated by peers and leaders from my system, and then chosen as one of the top 20 in the region. And this was for my work in the development of our PBM and bloodless medicine program for patient advocacy, collaboration, outreach, and education to providers, staff, and patients, and promoting PBM and bloodless medicine as the standard of care. And this was all in the face of the same obstacles that so many here have experienced, particularly as a nurse promoting this practice and culture change. So it really was a true honor to be recognized and to be able to represent PBM and bloodless medicine in this way.
Congratulations, Mindy.
Thank you.
Let me ask, what is the setup like with your bloodless medicine and surgery program? How do the workers achieve synergy for good clinical outcomes?
So our program is much younger than my fellow panelists here. I'm more patient-facing at the hospital where I sit, and I'm supporting the program throughout the system. I started in 2019. Our 7 hospitals had just merged, and then COVID hit. And when I started, there were already some discussions in place for program development, but after I started, a system-wide process for identifying and supporting patients for whom blood is not an option, and a system policy were developed and approved. We have now a required power form through our electronic medical record that was developed and approved. And this power form is completed by nursing. It walks them through the process through mandatory fields. It addresses patients' wishes and advanced directives like the ones carried by Jehovah's Witnesses. And as many others have demonstrated this week, we've developed patient educational resources and a worksheet to assist patients in expressing their specific wishes. And then also that, in addition, aids providers in the informed choice discussion. So this packet is also available in Spanish and Portuguese, and it's provided once the patient's wishes are identified so that there's at least some support at the very start of the hospital encounter. So these processes required much collaboration with many departments. It was already mentioned, this is a team sport, right? So many providers, leaders, and staff, the medical and nursing professional development and education departments were very supportive as well, and many more. And I really feel that achieving synergy is more of a constant process. It's accomplished through education and recognizing gaps in care and working to support opportunities for improvement. We have required onboarding and yearly education. I speak at department committee and staff meetings with leadership, individual providers to gain support. I invite experts in the field to speak on relevant topics for CME CEU credits, and promoting educational opportunities such as this week, PBM Awareness Week, World Anemia Awareness Day, And we also have content with many educational resources and links for our providers and staff in our system's internal intranet site. I've additionally been able to recruit and train a team of RN champions throughout the health system who are volunteers to help support process improvement and patient support staff education, and a training program for our nursing supervisors who are on call after hours and weekends for urgent matters. So the education really is constant.
I'm completely with you on that. In fact, the theme of our last annual meeting, 2022, was on education as being key to actually moving bloodless medicine forward. It's not so much about technology. Much of it is the knowledge of basic things, common sense. Thank you for all you're doing in that regard. Now, let me ask, it's been a limited period, but what have the outcomes been like within that time? And how do your patients feel about the Bloodless program?
Yeah, so through these efforts, I've gained support of many senior leaders throughout our health system. This, I feel, has been really the key driver in the appointment of our executive sponsor for the program, our Chief Quality Officer. We're now on the verge of having inpatient iron deficiency anemia optimization guidelines that are approved through the use of our HEMONC governance. The goal is then to create power plans to support evidence-based clinical decision-making, and then kind of guide them through the process of deciding when to make the referral versus what can I do, when can I use IV iron versus oral iron. And then our OBGYN service line has joined forces with us for multiple PI projects involving anemia and pregnancy and targeting patients with several GYN issues. And then with the support of our system chief of surgery, we are working towards implementation of outpatient and preoperative anemia optimization programs. So there's really a lot going on. It's moving very fast, and it's very exciting to see all the efforts produce positive results. Really, it's just all to the benefit of our patients. And of course, we don't have enough time to touch on all the details, but some of the most important, I feel, are about the patients. I feel like my team and we receive thank you notes and phone calls on a weekly basis from patients and family members expressing their deep appreciation for the wonderful care and support of their wishes.
So obviously, your patients are very happy about the program.
Yes, thank you very much.
Thank you for the work you're doing. So is Deborah here now? I don't see Deborah, but that's okay. Tanisha is here. Let's hear from Tanisha. Tanisha Davis. As we mentioned earlier, Tanisha Davis is Administrative Director, or did I miss? No, I didn't miss it. She's an Administrative Director of Patient Blood Management. Tanisha, are you a nurse?
I am not a nurse. I am a non-clinical girl.
That is wonderful. So we need to know that we don't have to be physicians or nurses to actually do some work in Bloodless. So let's hear how long your PBM program in RWJ Barnabas Health System, how long has it been there? I learned it's evolving now into a bloodless medicine program.
Right. So it started, our healthcare system is 12 acute care facilities spread throughout the state of New Jersey here in the United States. And it started all at one hospital, one of the flagship hospitals, and it started as blood management. The intent was to do bloodless, but once I came across the medical director, Dr. Fizade, he says, no. He says, we'll do blood management first. He says, because he didn't want to pigeonhole the program as just for a specific type of religious people. And then he says, once I could get everyone used to using less blood, the last piece will be a piece of cake. And it just so happened that our CEO moved on and got a position as the CMO of the health system as it continued to grow. And he's always been a big supporter. And so once he got that position as the CMO and Chief Quality Officer, he decided that it was something that should be done throughout the healthcare system. And that started about The hospital portion started in 2009. However, the health system started in 2018. And once Dr. Bonamo decided that it should be system-wide, it's so funny, the first thing we went to Johns Hopkins and we asked them for help, how to do this. And Dr. Frank and his team has really been holding us by the hand ever since then. So we went from a process to now really looking at our bloodless medicine piece and putting all the pieces in place to have a real program and not just a process to take care of these patients.
Thank you, Tanisha. You've raised a very important point. Whenever the term bloodless medicine is brought up, everybody's mind goes to a particular religion, right? People generally don't look at it from the scientific point of view. And that causes a whole lot of problems. Sometimes we have patients who come in desiring bloodless care, and they are denied that bloodless care unless they claim to be Jehovah's Witnesses, which they do sometimes. And our keynote speaker on Monday raised that point, that patient blood management is great, but our ultimate destination scientifically, bloodless medicine for all, because it is just, it's scientific, it's the correct thing to do. And what stands between us and that goal is ignorance. People are believing things that are not scientific. Blood transfusion, it saves lives. How? How exactly? And nobody can answer that question. Does it improve tissue oxygenation? Of course not. And so on. But let's get back to your role. How, what does your work involve? Because you are a bloodless medicine program administrator. So what does that, administrative director. So what does it mean to, what do you do?
So basically, I'm responsible for blood reduction and blood avoidance, and I oversee all of the administrative and operational aspects of establishing, developing, and maintaining the health system's blood management, and we call it transfusion-free medicine and surgery program. So I make sure all the protocols are developed, all the procedures are developed. So you have your policies, your procedure, your clinical guidelines. I'm responsible for finding talented clinicians to have them to join our program. I'm also responsible for data and making sure that we can access the data, but not just accessing it, relaying it to the physicians as well. And then I also have a staff that I'm really proud to have. We have to have boots on the ground. So we do have 2 of our sites that actually have staff that supports the program. And then I'm also responsible for guiding how this is going to be implemented across the healthcare system.
What
I'm sorry, I couldn't hear you.
The C-suite, isn't that the kind of cadre, the letter C and SUITE? Isn't there terminology like that?
I'm sorry, Nathaniel, I didn't hear you.
Okay,
can you say it
so
one more time?
I'm asking, are you an executive worker, someone in the executive cadre?
Yeah, I'm an administrative director. So I work for the healthcare system. I don't work for any particular hospital. Actually, I have all 12. So
we are privileged to have someone of that caliber here with us, because we are usually talking to small fish like doctors and nurses, but now we have someone who is high up. Now, let me ask you, how important is cooperation and synergy among the workers in your PBM/bloodless medicine program?
Oh, it's number one. That's number one. I always say teamwork makes the dream work. And everyone in that department is important. The administrative coordinator, if I don't have her, then no one can get access to the clinic. And so we can't give preoperative iron. We can't do the things to make sure that the patient's in the best position that they can be in before they even go for elective procedures, we have a registered nurse. And so she's the one that actually administers the drug. And then we have a clinical navigator. She's responsible for the healthcare education. She's responsible for making sure the hospital forms are filled out. She provides that health education so that the patients can make the best informed choices as to the treatment options that are available, that they will be comfortable with accepting. And then we have a nurse practitioner, and she's the one that actually puts together the care plans, and she sees the patients and she manages them. And then, of course, we have our medical director who gives us the clinical leadership and makes sure that the health education that we need, or the clinical education, is there to be able to take care of these patients. So teamwork is essential.
Thank you very much, Tanisha. How successful has your program been, and what impact has it had on your patient life?
So that was a tricky question, because I think it depends on how do you define success. And I had to really give that some thought, because sometimes your own personal definition of success can blind you to the wins that you've actually had. I thought about when our program was just a process. We had successfully managed a mom that was 24. She delivered at 24 weeks. Her baby was 12 ounces, and she survived. And so everything wasn't the way that I wanted it for our program, but she just was able to give her story on our website and how much the program meant to her. And that was success. Even though it wasn't the way I wanted it, that was very successful. And then now that we have a lot of the bells and whistles that I wanted, and the clinical guidelines and the policies, and now we have this big team, we just had a patient that came through with a GI bleed, and her nadir hemoglobin was 4.2. But in the operating room, it was undetectable. And we were able to manage that the way I always envision, get her straight to the OR, and to be able to just do things just like clockwork. But it helped me to appreciate that either way, we were successful. And we can only do that because of the support of executive administration, because we have the support of clinical leadership, and because we have platforms like this, where we can meet people and they share their knowledge, and we can continue to grow and support one another.
Tanisha, anytime I need a job in a Bloodless program in the US, I'm going to call you. Thank you very much.
You're welcome.
Let's speak with Dr. Monday Godwin. Dr. Monday Godwin is unusual. He is a consultant obstetrician and gynecologist, not in the US, but in Nigeria, and working with the Nigerian Air Force Hospital in Ikeja, Lagos. And he offers bloodless care to his patients. How long have you been doing that? And what has the reaction been like?
All right. Well, I want to say that I've been in this forum for a while. You can testify to that. I'll call myself a doubting Thomas. Initially, I never knew that this could work. And I've been an observer and asking several questions, particularly concerning my field, because it's a field where we dine and wine with blood, so to say. Yes, so I looked at it as not very practicable. But after following the system for a while and decided to put one or two things together, I would say I've been practicing giving my patients bloodless care for the past 2 years.
That's wonderful. So what surgeries so far have you been carrying out bloodless in your center?
Yes, I carry out challenging surgeries, such as in the obstetric aspect, I do cesarean section with multiple previous scars, which have risk factors for additions, and also do cesarean section with placenta previa. These are highly risky surgeries that the risk of bleeding is very high. And also, I do cesarean myomectomies and hysterectomies. I do them without blood.
Do you have a cell saver?
No.
You don't have a cell saver, and you're doing these things successfully.
Yeah. Successfully.
So, okay. So in this period of time, I wouldn't want to put you on the spot, but like, how many patients have you lost?
Have I lost? No.
From bloodless?
For the past, no. In terms of loss of patients, I said 100% of patients have been successful in our life.
You see, this is what people, I had to say this wasn't a scheduled question, but I just had to ask you because people don't believe it. You know, I will still get back to ask Dr. Frank, so he knows that I will ask him now. But you have been doing this without the technology, and still getting a better outcome, suggesting that blood transfusion is actually responsible for a lot of the bad outcome, as science itself has shown. And okay, but this aspect of you offering your patients bloodless, let me ask you, how many patients reject it when you offer them the bloodless service?
To be candid, many of the patients are not privy of this option of bloodless surgery. In fact, when you suggest it to them, the question they ask is it possible? And when you reassure them that it is possible and you give them your experience, they opt for it. Of course, you know, we have the Jehovah's Witnesses who primarily do not accept blood. This one's come sourcing for it. So far, no patient has objected to it.
Again, that is very instructive, because if we did our job as physicians to educate patients, obviously nobody would go for blood transfusion. What would the education involve? We would have to tell patients, okay, look, you have two options. Either you take a transfusion, which is known to increase the morbidity and mortality, you're more likely to die or to be sick, or we go for the bloodless, which has a better outcome. How many patients will reject the bloodless? They wouldn't reject it. And your experience bears that out. Do you have anesthesiologists who anesthetize for you, hematologists, I mean, like support staff, nurses who are willing to cooperate with you in this work?
Yes, I have support staff, but in terms of their support, I would say for the nurses and the hematologists, their support is a passive one for now. I think they are still in that state I was initially, observing and asking questions. Perhaps in the future, they'll key in fully. However, for the anesthesiologists, I would say they are supportive in terms of the technique they use for the surgeries. The techniques are actually inclined towards bloodless surgery. For example, the hypotensive anesthesia they give, the hemodilution they apply, and also it's a routine in my center to use antifibrinolytic drugs like tranexamic acid, which was discussed in this platform. And also in the event of significant blood loss, the first option is usually a colloid, and the colloid I use often is Imacel. So far, I would say they are supportive.
To ask you a technical question, how do you plan your bloodless surgeries in order to achieve success? Because we say that bloodless surgery is not carrying out surgery without transfusion. It is actually planning surgery to deliver quality care without the use of allergenic blood, with the aims of improved outcomes and protecting patients' rights. So that requires planning and protocols and doing things properly. So how do you do this?
First and foremost, the first contact of when I meet my patient for the first time, I thoroughly evaluate them clinically, identify those ones who have anemia, and try to find a root cause of the anemia and then manage it. I counsel these ones in terms of their nutrition and then give them hematinics. So this is aimed at optimizing their hematocrit level prior to surgery. Now I want to speak on myomectomy, which is one of the gynecologic surgeries I perform so much. So for such ones, I plan their surgery during their proliferative phase, the follicular phase, the first 10 days of their menses. During this period, they are likely to lose less blood. For those ones who present with symptomatic uterine fibroid, that is indication for the fibroid itself is heavy menstrual flow or prolonged menstrual flow. For such ones, that menstrual cycle that precedes the surgery, I give them some medications that helps to reduce the menstrual blood loss. so that at surgery, we still have significant blood loss and significant blood left in them in terms of the hematocrits. And during the surgery proper, for my myomectomy patients, I found the use of uterotonics such as misoprostol very helpful. So 1 hour to the surgery, I pass it rectally to help contract the uterus in the middle of the surgery. And like I said earlier on, the anesthetists have been supportive. So they bring in these techniques such as a protective anesthesia, hemodilution, and then use of tranexamic acid prior to the surgery. And also the position of the patient too also helps. Now, intraoperatively, I'm privileged to have a surgery machine, the item in my facility, although it's not a prerequisite because before it was available, I did the surgery without it. But now that it's available, it's also advantageous because it helps to further minimize the blood loss. So I use this, and once I get access to the uterus, I use my tourniquet. That helps to actually reduce the blood loss during the surgeries until after I finish inoculating the fibroid nodules and then close it proper and allow the tourniquet. So during this process, and also again, I want to emphasize that I treasure much blunt dissection, if need be, in favor of against sharp dissection. So I go in for more of blunt dissection. And also, I'm also meticulous in the surgery. I try to avoid any places I see prominent surgical vessels, which I know just touching them can trigger bleeding. After the procedure itself, I look at the amount of blood loss. Provisions will have been made for Imacell, the colloids, and also other immaterials we talked about. For those ones that happen to have significant blood loss, we'll start them with the colloids, Imacell, and then follow up post-operatively with parental iron, parental vitamin C, B12, and then EPO. Erythropoietin is given to these ones. And observe, in addition to other post-operative medications that are given, like antibiotics, analgesia, and discover that these patients do very well. And for my cesarean myomectomy, yes, I have to come in here so that people may want to ask questions. Once I deliver the baby, I ensure that the uterus, secure hemostasis with my green amputation, ensure the uterus cavity is totally cleaned, and then I applied my tourniquet. Once I apply my tourniquet, of course, the bleeding will be arrested, and then I try to inoculate the fibroids. And after inoculating the fibroids, in fact, I go ahead to close first before I let loose the tourniquet. It's called at the end of the day, the bleeding is minimal. And for those ones that the bleeding may be significant, like I said, starting with colloids like Imacell, then follow up postoperatively with the parental iron, the erythropoietin, the vitamins B12, and other medications, and the recovery is superb. I discharge my patients on post-operative day 3 or 4.
That's wonderful, Dr. Godwin. So cesarean myomectomy, that means that you're doing a cesarean section and then you're doing a myomectomy at the same sitting.
Yes.
That is something that many surgeons will be scared to do, even those who believe in blood transfusion and the blood is available, they'll be scared to do it. But you are doing it without blood transfusion.
Yes.
And to think that you started as a doubting Thomas. So this shows the importance of education, because you were coming around, you were attending the seminars, workshops that we were holding. And of course, when we went online, you joined. And here you are now, an apostle of bloodless medicine, now going to bring other people in from your center. I wouldn't ask again, what is your success rate? Because already you've told us that you haven't lost any patient. And that is just wonderful. Thank you for the good work you're doing.
Thank you very much.
I think we've heard much from the clinical staff, the workers in BMSPs. Let's hear from the other side, that is the patient. And we'll start with Lisa Evanson. Welcome, Lisa.
Thank you.
So you had bloodless surgery recently. What bloodless surgery did you have? And of course, you can tell us first about yourself, because we didn't really introduce you. So you can tell us a bit about yourself and then the surgery you had, when you had it, and why it was necessary for you to have it.
Okay, I live in Florida. I developed this crazy cancer, unbeknownst to me. And it took a while to figure out what it was. But it turns out that I have appendiceal cancer, stage 4. So I had an approximately 10.5-hour cytoreductive surgery, including hot chemo, 90 minutes of hot chemo in my abdomen, which is called HIPAC, on September 26, 2022. After this stage 4 appendiceal cancer diagnosis, it was necessary for the removal of several organs and the scraping of my diaphragm due to the spread of cancer there.
10.5 hours of surgery.
Yes.
And bloodless surgery. Was it your choice to have bloodless surgery?
Yes, it was my choice to seek bloodless
Why?
surgery because of my religious convictions based on Bible teachings in harmony with Acts 15:29 to abstain from blood.
Okay, so you are Jehovah's Witness.
Yes, I am.
So how did you go about seeking for and obtaining this bloodless care?
I interviewed several surgeons around the country, and I worked with a group of volunteers who helped me to research any doctor that I was considering with regard to reputation and cooperation with bloodless medicine.
So they helped you to locate a doctor.
Well,
And,
yeah, they would research for me. When I would choose a doctor, they would do the research and tell me whether it was a good fit.
And where did you find this doctor? Was it in Calabar, Nigeria?
Ended up being in Baltimore, Maryland.
Right. I think
Johns Hopkins.
Isha had mentioned that one of her patients was on, and that should be you. So
Yes.
let me ask you, what steps did the doctors take before even the surgery to ensure that the surgery would be successful? And this is very major and challenging surgery for any surgeon at all.
Well, they made sure that my hemoglobin was optimized before surgery. On the day of surgery, they made sure that all parties involved were aware of what products and procedures I was willing to accept according to my medical directive. And then they used meticulous surgical techniques during surgery. Post-operatively, the bloodless team monitored me closely to ensure my hemoglobin was still optimal.
So we refer to this optimization of hemoglobin as the first pillar of bloodless surgery. So really they started at the right place. And you said they made sure all parties involved were aware of what needed to be done. That is operation in a multidisciplinary setting, which is what we're emphasizing here. When we say all together now, we are in sync and we work together to make the patient come out better or well. So how did the surgery go and what was the outcome of it?
I had a complete cytoreduction. And despite that extensive surgery, I lost only 12 ounces of blood. And I attribute that to the expertise of Dr. Fabian Johnston and his team, including Dr. Frank.
That is great expertise indeed. For those of us who deal in mils, milliliters, that 12 ounces interprets to 354.8 mils. That's less than a unit of blood. The unit of blood is 500 mils. And that for cytoreduction surgery, that is remarkable. It's almost unbelievable. So do you have any regrets for choosing bloodless surgery? Or were there any benefits?
Well, absolutely no regrets. I knew that any surgeon that was willing to do such a heavy surgery without the use of blood would have the skills necessary to save my life. And it also gave me peace of mind knowing that he would respect my wishes about the use of blood.
Thank you. So any final thoughts you'd like to share with the audience?
Well, bloodless treatments were developed to help Jehovah's Witness patients. And now these treatments are used to benefit all in the community. Although I'm not happy to be on the receiving end of such a devastating diagnosis and surgery, I'm grateful for everyone who pioneered bloodless surgery, all who continue to make great strides in this area, and especially to those who achieve such a high level of skill that they're able to make the impossible possible.
And honestly, Lisa, looking at you, you don't look like someone who had that kind of surgery just a few months ago, less than 7 months or so, 8 months ago. Thank you very much for sharing your experience, Lisa. Thank you.
Thank
So
you.
let's now listen to Dr. Joseph. Doctors also had bloodless surgery. And we'd like to know, doctors, what bloodless surgery did you have? When was it? And why was it necessary?
Okay. The surgery I had was myomectomy. That is the surgery for fibroids. And it was done this year, January 2024. I was actually having this recurrent episode of severe pain in my lower abdomen. The pain was becoming unbearable. So I had to go for a surgery.
So was it your choice to have bloodless surgery? And if so, why did you opt for it?
Yes, because personally, I'm against blood transfusion because it is against my Bible-based belief.
I see. All right. So how did you go about seeking this bloodless care and obtaining it?
Okay. Because I'm against blood transfusion, I prayed before my surgery to meet a doctor that we agreed to carry out the operation without blood. Fortunately, I was able to meet a surgeon that shared the same view with me. I was very happy.
Wow. That sounds like a shorter route than going everywhere and searching. You prayed and your prayers got answered. Thank you, doctors. So where did this prayer that was answered, where was it at Johns Hopkins? Where did you? Am I the one who's frozen or Dorcas is frozen?
I think the problem's on Dorcas's side.
Okay. Dorcas, if you can hear us, it looks like your network is fluctuating or gone up. So we'll get back to Dorcas when she's able to join again.
I'm with
Please,
you.
Lydia. Oh, you're back.
Yes,
Oh,
I'm back.
All right. So, all right, great. So I was trying to find out where you found this after the prayer. Where did you find this doctor that is willing to do your bloodless surgery? Was it in Johns Hopkins?
Okay, it's here in Nigeria, Lagos, Ikeja. That is in Air Force Hospital.
Wow, that's wonderful. So what steps are you aware of that the doctors took to ensure that the surgery was successful even before you had the surgery?
Okay, before the surgery, the doctor encouraged me to take a lot of vegetables, a lot of fruits, and he also asked me to get a blood expander and other medications that are necessary. Then he also asked me to go for my PCV test so that we know if the blood counts will be okay for the surgery.
So when you found out the blood count, was it necessary to give some medication to raise it further?
Yes, I had to take some medications.
Do you remember any of them?
Hematinics, and other blood tonics.
Whether like injectable or tablets, was there anything like erythropoietin and so on?
Some were tablets, some were injectable.
I see. Okay. All right. Your doctor is here, so maybe you can tell us what the medication was if we really want to know. So how did the surgery go and what was the outcome?
I must say it was very successful. Nothing went wrong. If I don't say that I actually undergo a surgery this January, will you be able to see that on me?
I couldn't tell. Couldn't tell at all. I think you must have been praying again after you found the doctor. So do you have any regrets for choosing bloodless surgery, or were there any benefits?
There was no regret at all because I actually recovered very fast. A day after the surgery, I was able to walk around the hospital. And 3 days after the surgery, the plaster was removed. The surface of the wound was very clean. I was so amazed, very happy.
That's wonderful. So do you have any final thoughts you want to share with the audience?
Yes. My wonderful audience, what I have to say is that if it happens that there is a need for a surgery, I will encourage them to seek for a doctor that will be able to carry out the surgery without blood, and also take some necessary medications because it actually aids quick recovery physically and psychologically. And again, it will aid good conscience with the originator of life, which is Jehovah God.
Thank you very much, Doka. So it all started with protection of patient autonomy, that is patient's rights. And now it is moving to outcomes. And even though Dorcas is not a doctor, she's telling us first about the outcomes. There's going to be better outcomes. And then add on top of that, a good conscience with Creator. Thank you very much for sharing your experience, Doc. Let us now speak with Irizim, another third patient, Irizim Gania. Welcome, Irizim.
Thank you.
Tell us about yourself a bit. What surgery did you have? When was it? And why did you have to have the surgery?
Okay. I am from Nigeria. I live in Lagos.
Excuse me, sorry to interrupt, but I think they've got more than one device in the same room and we're getting some feedback. That's it.
Do you have another device in there?
Yes, sir, but it's taking out.
Okay, great. Okay, yes, start again, please. Let's hear what you have.
So I said I'm from Lagos, Nigeria. So actually the surgery that I went for is for myomectomy, the removal of fibroid. And it was done on the 6th of this January, 2023. And the reason for the surgery is because I was having a heavy flow, monthly flow of my menstrual cycle. And also I was also trying on conception. So I had to opt for that.
Interesting, because I think just this last weekend, there was a Bloodless webinar hosted by University of Chicago Medicine on fibroids. And they did point out that for a lot of women, their complaint is heavy flow. For Dorcas, her complaint was severe pain in the abdomen. Yours was heavy flow. And that is a kind of bigger problem because it makes it difficult for the surgeons when there's much blood loss and the blood level is low.
Yes.
So how did you get to know about bloodless surgery and why did you opt for it?
Okay, my doctor that was in charge of my case actually told me about the bloodless surgery. And again, I actually never wanted to have a blood surgery because I've had past experience about blood transfusion when I had my first child during an emergency surgery, and they had to opt for a blood transfusion, and I had serious reactions to it. So since then, I never wanted such. And when he introduced that to me, I was very excited. I was glad and I embraced it because he encouraged me that it's going to go well. So I trusted him with that.
So presumably you're not a Jehovah's Witness. Am I correct?
No.
Right. So this is the principle of justice in medicine, because when we talk about medical ethics, it's patient autonomy. That's number one, protecting patients' rights. Then there is beneficence. What we're doing should be beneficial. In fact, before beneficence, there's non-maleficence. What we're doing should not harm the patient. Then beneficence should benefit. And then justice, that we should be fair to all. Every patient is entitled to an improved outcome, including those patients who may not decline blood transfusion. And so your doctor was proactive, actually educating you, and then you opted for it. I think that is a fine example for us, for all of us in the medical practice, that we should do that with our patients. We don't need to wait until a patient says, I don't want blood transfusion. Then we say, are you a Jehovah's Witness? Patient said, no. Okay, you have to get 4 units of blood. No, that's not right. Now, what steps did the doctors take to ensure that the surgery was successful?
Actually, he had to engage me on some tests, to run some tests, and also to know my blood PCV level, because even before the surgery, I have still been bleeding. So the date of the surgery, I was still bleeding. So, but we have to go for a PCV test to see my blood level. And also, he also advised on taking blood expanders that will help boost my blood level. And also he recommended drugs that will help to reduce the flow of blood before the surgery. So that really helped a lot.
Thank you so much. How did the surgery go, and what was the outcome like?
The surgery actually went very well. I was very optimistic and positive about it because I believe in God and I like positive people around me. He has been very positive, very encouraging. The surgery really went very well.
So happy about that, Irisi.
Yeah.
So do you have any regrets for choosing bloodless surgery, or were there any benefits?
No regrets whatsoever. I can campaign for that. I can advertise for that. I can tell people about that because it really went well for me and no regrets at all.
Thank you for that. Any final thoughts, anything else you'd like to share with the audience?
What I want to say is I think more awareness should be created about bloodless surgery because we have a lot of people out there that do not know about it. Awareness should be created to let the people know about it. And also, if, yeah, I think basically that's that about that. And also to let them know, just to know about how important and how effective it is. There are so many out there that do not believe it. So, but I want to tell them that it's real. I have experienced it and it's very effective and it's very easy to save life. Instead of running for blood, at times you may not find the real blood around. You don't know the source of the blood. You don't know how it has been preserved. So, but with this, it's very easy. That's what I can say.
Thank you very much. You're absolutely correct. Because I think the Guardian newspaper in Nigeria a couple of years ago interviewed some experts, WHO and others, and they said 95% of the blood in low resource settings like Nigeria, and Nigeria also, 95% are unsafe. They are not safe. So I think that point you made is very valid. Thank you for sharing your experience with us, Irisi.
Thank you. You're welcome.
Yeah, wish you, well, you already recovered. So I still wish you continued recovery.
Thank you so much. I appreciate it.
Before we come to an end, let's go back to where we started with Dr. Frank, Dr. Stephen Frank. Lydia, can you bring him into the room? Right. Welcome, sir. Let's go back to the issue of your outcomes. How has it been? How many patients would you say you have lost? Let's say in the past year. I know you do the high volume setting where you do a lot of surgeries, and even the spectrum of surgeries. By the way, we're watching your videos on Tuesdays. We're watching one of your videos that explains bloodless medicine and surgery, and another one that also talks about the benefits, 2 of your videos. So, but let's hear it from you. What has it been like? How many patients have you lost that you can say is because they didn't take blood transfusion, that's why they died?
Sure. How many patients have we lost in 10 years? We have lost patients, but it's not strictly due to anemia and lack of transfusion. for example, I would say 3/4 of the time they die from sepsis or pulmonary embolus or infection. So the things that really sick patients die from, even when they get blood, that's if we lose a patient, it's usually due to those causes. Honestly, the only patient I can recall who died strictly from anemia, I can remember two patients.
In 10 years.
Yeah, one who tore her scalp and she had a huge laceration in her scalp, and she was found down in the field, bleeding for hours, and she came in with a hemoglobin of 2.8, and then it went lower from there. So it was we even gave her a hemoglobin-based oxygen carrier, which is, you know, a blood substitute, which is not even FDA approved. And even that wasn't enough to save her because it was too little, too late. Her lactate was 18, her pH was 6.9. So that's one patient. And then the other patient was just recently hit by a car while walking her dog. And this is like 2 months ago. And she came in with a fractured pelvis, a fractured femur, fractured humerus, and contusion in her chest. And she was bleeding into her pelvis from her fractured pelvis. We tried to embolize her pelvis, and her hemoglobin drifted down below 3. And within 3 days, her pH was under 7, her lactate was 20. And we didn't even think that the hemoglobin-based oxygen carrier, like Hemopure, we didn't even think that was going to save her because she was in such bad shape. So I recall, do you remember any others, Isha? Those are the two patients I recall who probably died from their anemia.
So I needed to ask you this because we've read your papers, we've listened to you talk at conferences, and you have always made the point that the outcomes are better when bloodless cases are done. In fact, I think you're one of the foremost people left in the world still ringing that bell seriously. So we needed to hear it from the horse's mouth. What message do you have for clinicians and patients regarding bloodless care?
Well, the message is that keeping the blood in the patient is where it's at. Like when basically 3 out of 4 methods we use are designed to keep the blood in the patient, like tranexamic acid, keeping them warm during surgery, smaller phlebotomy tubes. All these things are designed to keep the blood in the patient, and that's the message. And the patients do better. We showed that hospital-acquired infections are more prevalent when patients receive transfusions. So, you know, banked blood has an immunosuppressant effect. So if you can avoid blood, you're probably at lower risk for hospital-acquired infections, which happen to be the #1 killer in the hospital.
Thank you very much. Before you go and before we wrap up, there are a couple of questions here in the Q&A. Somebody's asking, just curious, as a volunteer in Bloodless Medicine at Johns Hopkins, how do you balance your other unit assignments, hearing how busy your schedule can be? So I think I brought that problem. I said we start as volunteers. It doesn't mean that we end as volunteers. Sometimes the system recognizes what we're doing and actually sets up structure and recognizes us and perhaps even pays us. Some of us don't get, I think I'll ask God whether he gets paid for the work they're doing. But this question, I think, is meant for the people in Johns Hopkins. So maybe you can answer that.
So how do I balance my other jobs along with this? Because of our team members. because Isha right here, Liz, Patrick, Linda, and Andy, they follow the patients every day, and they do most of the work that keeps the program running. And then when they need medical advice, they consult either me for perioperative questions or Linda, our hematologist, for anemia management. And so it wouldn't work without a team, and we need funding from the hospital to support the team. And we've shown that for every dollar we spend on our Bloodless program, we bring in $7 in return. And so that's how you get money from the hospital leadership. And we're gonna present that financial model and results at the American Society of Anesthesiologists and at SABM this fall, showing that for every dollar we spend, we get $7 in return. So other hospitals can tell their leadership, hey, we need support for our program.
I'll start applying for my visa now because I need to come and hear the story. Isha, you have a comment on that?
Oh, I 100% agree with Dr. Frank. And I think what was nice about our program is though we work in harmony with patient blood management, when we were first established, we were established individually as a bloodless team. And so the benefit of that was since we had the funding, we were able to build a team that would be able to have continuity of care from multidisciplinary aspects for all the patients that we see. And so that has definitely been a blessing. We know that all programs can't be set up that way, but that has truly been the anchor for our program, is being able to have patients see all of our coordinators throughout their time that they spend here at Hopkins, before, during, and after. And so by doing that and having a solid team that really has been able to divvy up the responsibilities and make sure that our patients are still getting the best standard of care with patient autonomy, but having the support continuously along the way.
Thank you, Isha. I think Sarah wanted to say something as well. Sarah Walbot.
Hi, I think I accidentally volunteered to answer that question, but for anyone who's looking at possibly getting more involved in their hospital in bloodless medicine or patient blood management, I started off as a volunteer. So I worked in the gastroenterology department, and I think that making yourself known to administrators, to your unit manager, and saying, I have this special skill or knowledge. I understand the bloodless care population. If we have one, I would like to be a patient advocate, or whatever your skill set is. I started volunteering. I just said, I could cover on-call or weekends when the current staff needed holiday coverage. And that worked really well. And that's how I got involved. And it wasn't any time at all, it seemed like. And, they had more needs, and I became more and more involved in a paid aspect. But this is a value that you do bring to your hospital organization. And so even just letting your unit managers know that you are able to serve in this way, then when they have a patient that your skill set could be needed for, possibly they will even lighten your load in your home unit so that you can take care of a patient in a specialized way. So don't be afraid if you want to be more involved, and whether you have a established program or not, to make yourself known and what you can do for the hospital system, and you'll probably find support.
I do some sleep, but you find support. Okay, thank you, Sarah. There's a question here about transplants. Dr. Frank and Dr. Waters, if Dr. Waters is still there, says, can you see the question? Patient was told can't do live transplant with IgG4 and tips being done. They said too much blood lost. Dr. Waters and Frank seemingly suggest may not be an obstacle. Comments?
Well, I should say that Pittsburgh was the birthplace of liver transplant. So if Jonathan's still on, I value his opinion, because when we started doing liver transplants back in the 1980s, we sent our providers to Pittsburgh to learn how to do them. And that's where Jonathan practices. So now we do about 120 liver transplants a year here, which is one every 3 days on average. And I'm on the liver transplant team. It's definitely the biggest case that we do in terms of potential bleeding. However, we about 10% of our livers now get no blood. We're heading maybe towards 20% that get no blood. And
this has nothing to do with declining, right? It has nothing to do with the patient declining.
Correct. Yeah. We have not done a Jehovah's Witness liver transplant yet. Okay. But we have 2 patients who are candidates, and we're working them up now to receive a liver transplant. So we're getting ready to do our first one, and they will probably get a live donor, so a family member or a friend who gives the right lobe of their liver, because that way they can get their transplant before they get really sick and coagulopathic. And so it's a much better chance of not needing blood.
Thank you very much. Let me quickly ask, do you come across patients who are not Jehovah's Witnesses, but they decline, they don't want blood transfusion?
Yeah, I would say about 10% of our bloodless patients that we follow are not Jehovah's Witness, and they have personal reasons, or they want to avoid the risk of transfusion. And we treat them like we treat all of our bloodless patients, and we don't ask questions why or about religion, but about 10%.
Thank you very much.
Yeah.
Also, too, we have been getting more and more calls for patients who they're not able to find blood for them worldwide, whether that be an OB patient, whether that be sickle cell patients, and a lot of patients who are being worked up for transplant. Their physicians are looking for ways to minimize the amount of transfusions given to them. And so our hematologist and our nurse practitioner have really been answering those calls to see how these patients can be treated without the use of blood.
That is great. And someone is asking, since blood transfusion doctrine begins in elementary stage in medical school curriculum, university, etc., noting the obvious advantages of bloodless management, is there any effort to gently push bloodless medicine and surgery into the primary strata of learning? What are the challenges and possible approach at addressing the issues involved? So this was discussed extensively during the last annual meeting of the Bloodless Medicine and Surgery Society. In my own center, I can say that we have it in the curriculum, certainly in surgery department. And I am teaching up to 4 hours of bloodless, and as well as blood transfusion problems. I don't know whether Dr. Frank, you want to say something on that?
Sure. Most of what our medical students and residents are learning is when they're on the wards or in the operating rooms or the ICUs. So it's on the job training. And whenever we do a consult, for example, we attach 4 of our manuscripts that explain how we do it and why we do it. We attach publications to our consults, which are educational. And as far as the basics, preclinical lectures that in the medical school, we don't have a formal bloodless lecture yet, but we're working on it.
Mm-hmm. We do a lot of.
I'll send you my own lecture schedule. It will be great.
We do a lot of work with our OBGYN So they have allowed us to be able to be a part of their lectures. And so they have a session on patient blood management and bloodless medicine. And so myself and our admin coordinator were speaking to the medical students. And what was great is that they could ask any questions that they had then. And what we really pushed or drove home was to take this knowledge wherever they go. They may not all end up at Hopkins. And so little by little, like Dr. Frank said, we're trying to inculcate that education early on with our students.
That is great. Thank you so much. We're trying to do that too. Now, Dr. Godwin, could you bring Dr. Godwin on? A question: how can you manage a patient with previous mammectomy, 2 previous CS, and currently major degree placenta previa without blood?
Yes.
We're getting some feedback again.
You are muted, please. Unmute yourself, and the other device should leave the room.
Can you hear me now?
Yes.
Okay. So I must say this is quite a challenging surgery, but then it's very, very possible. The risk factors there is the additions we anticipate to encounter in the previous years and the fact that we have a placenta previa. Now, for such patients, if we have enough time, we want to optimize this patient, optimize the hematocrit, and make available all the things I spoke about during surgery. And in surgery, we want to approach it meticulously. Once we can successfully resect the additions, the next problem we have is placenta previa. There are 2 options of managing placenta previa. Some school of thought say you cut through it and you try as fast as possible to deliver the baby. But I don't follow that school of thought. I follow this other school of thought that believes in what we call sidestepping of the placenta. We make a little incision into the uterus and then advance and try to locate the lateral, advance laterally to locate the placenta and then deviate it a bit. Once the placenta, the membrane pops out, you rupture the membrane and you deliver the baby. By so doing, you are not cutting through the placenta. So the anticipated blood loss you thought of losing may not be there in the first place. And in the event of losing blood, and it's significant, like I said, we use our colloid is the first option of choice. And then we'll continue with the parenteral iron, parenteral erythropoietin, and then the vitamins we'll talk about. But I said, if I have such cases, I've managed those cases individually, but not as one. I've encountered placenta previa type 4. I tell you, we didn't transfuse that patient. I wouldn't bleed much. I've also handled several previous cesarean sections. In fact, this week I had three previous years, and there was no transfusion. It was even an emergency. No booking record. We went through it successfully, but we made sure that these other alternatives to blood transfusions were available. So it's very, very possible.
Thank you very much. You see, a lot of these questions are based on the misconception that blood transfusion is beneficial. That is, it actually confers benefits to the patient. And we heard it from the first speaker on Monday. It is an unscientific position. We are transfusing to improve tissue oxygenation. But we heard last November from a professor at University of Rochester who showed clearly, and he's not the only one, many have shown that blood transfusion causes hypoxia. We're transfusing, we're hoping that it will even reduce the blood loss, but transfusion increases blood loss. So what I'm trying to say is, once we understand that we are not adding value to the care by transfusing a patient, but we are actually exposing the patient to lots of problems. In other words, risk without benefit. In that case, we may not even ask this kind of question, because the more problematic the case is, the more important it is to avoid blood transfusion. Since it's not helping, but it's harming. And we may not have much time again, but let's see if we can take this other question that says, Dr. Frank mentioned HBOCs to a patient. I know they are not approved in the US at this point, but are in Africa 2001 and Australia 2011. how close are we in having these carriers approved in the US? And are they still approved in Africa and Australia?
Sure. Yes, thank you for that question about hemoglobin-based oxygen carriers, which have also been called blood substitutes. They're usually a bovine hemoglobin, acellular, so no red blood cells, and the molecules are polymerized, so they can carry oxygen and transport CO2, and they are not FDA approved. The question is, how close are we to FDA approval? I think we're no closer than we have been because of the obstacles the FDA is putting up against them and the lack of funding. These things are really expensive to make. And the only one still standing is Hemopure. And they have very few units left. They say that the ones they have been sent to South Africa for a trauma trial to gain FDA approval in the US. So we're even having trouble getting a hold of units for our patients, and we're only using them in specific situations where we think the benefits outweigh the risk. And these things are definitely not as good as blood. They scavenge nitric oxide, they cause vasoconstriction, they cause methemoglobinemia, which can be toxic. So they're not as good as blood. And the last 3 patients we gave it to, though, lived. And there is a sweet spot where you can save the patient if you give it, and it's not too little, too late.
Thank you, Dr. Frank. So I think that's the last question that we're going to take. There are some other minor questions. Please, you could help me, the panelists could help to type answers to these questions. And before I get kicked out, let me voluntarily leave. And I want to thank all the members of the panel discussion and those who made comments and everyone involved in the program. Evidently, bloodless medicine and surgery programs work. They produce good results, and the multidisciplinary nature is definitely part of what makes them work. Cooperation in the achieving of improved outcomes for all patients. So thank you very much for having me, and I'll hand over back to Jessica and Innocent.
I'd like to thank you very much. I have a feeling that there's some conspiracy to have me as moderator today. Monday Godwin, you don't know me personally, but I've been on your trail for a while. And I remember your doubting days, and it's indeed gratifying to know that you and your persistence paid off. Despite doubting, you attended virtually all the programs that arranged by this group and other groups. So I'd like to thank you very much. Dr. Frank, the smell of coffee in your office, each time I think about you, I remember the smell of coffee. And so I thank you too. And our guests, our patients, we're grateful to you for letting us know that it is possible to do bloodless work. Nat, thank you very much. Yvette, I'll see you soon. And I'm sure Richard can hear me. I'll see both of you soon. I'll just quickly like to speak on the question Dr. Gordon was asked. I managed one yesterday. 1 previous myomectomy, 3 previous cesarean sections, and you know that a previous cesarean section is a risk factor for placenta previa. So it was definitely expected. And the question is, what would you do with a uterus that has been cut 4 times? Would you want to keep it? The answer would be no. So hysterectomy is prophylaxis for postpartum hemorrhage, not treatment. So if you counsel that patient that because of the risk factor for massive postpartum hemorrhage, we're going to go straight ahead and have a hysterectomy, I'm sure virtually all the anxieties would have been cleared. So I also thank the participants for your intelligent questions. I am a noisemaker, so let me not talk too much. Jessica, please.
Yes, it was a great program today, and we really appreciate it. I think Dr. Gopay has one more comment. Would you like to speak, Dr. Gopay?
Yes, thank you. Now, first of all, I would like to congratulate the organizers and all the speakers and panelists for the excellent programs. Now, the one thing that I would like to share is regarding patients who are non-witnesses who are now asking for a bloodless management. And since I started speaking or preaching about alternatives to blood transfusion in the mid-1990s, when I started caring for Jehovah's Witness patients, I was branded as somebody who was crazy, somebody who was talking about a religious issue. And then I was telling them that this is more than just a religious issue. And then year after year, I noticed that the patients who wanted a non-blood management were doctors. And I said, look, the first doctor that asked for a non-blood management was an obstetrician who was operated on for ectopic pregnancy. And she said, Angie, no blood for me because my brother died from a fulminating hepatitis from blood transfusion. And then the second doctor said she had postpartum hemorrhages. And she said, give me all the injections I need, but no blood, please. And then recently with the patient blood management concept, I have been talking again about it in any time, any occasion that I can. And I got referrals from resident physicians from another hospital in our city here in the Philippines, okay, that in fact, this hospital, I am not affiliated with this. So the resident physicians would call me and said, Doctor, can you tell us how to go about managing anemia? I said, who is the patient? It's my father. So this time they are more aware of alternatives to blood transfusion, how to manage anemia without blood. So it's picking up.
Thank you. Thank you so much for your comments. And we really appreciate all of y'all from Texas on the program. And we still have one more day tomorrow. Can we put up our agenda for tomorrow? So we have bloodless renal dialysis from a pharmacist, Obed Adu from Australia. So that should be really interesting. And we also have our basic quiz contest on bloodless medicine and surgery. So we look forward to having all of y'all on for tomorrow. Thank you.